all of you. Actually, we have it's a nice course on refractive surgery. When you think you know it all, you have that urge to learn that little more, which will refine your refractive surgery. And all the speakers in this session, excepting 2 youngsters, have been in the practice for the last 2.5 decades or nearly 3 decades. So, there's so much of information which will come across. So please stay glued onto your seat. I'm sure you will learn a lot. We are truly lucky to have our first speaker, Dr. Kumar Doctor here, who has been doing as a doyen in refractive surgery. He's been there right from the inception of refractive surgery in our country. And he's going to be, heads the Kumar Dr. High Hospital and is a great entrepreneur. And he's going to be talking on update on epithelial mapping and relevance in refractive surgery. And it's a very important topic because a lot of decision takings are now related to epithelial mapping. So on to you, Dr. Kumar.
Good morning, everybody, and thank you, Chitra, for the nice introduction. So I'm going to talk on epithelial mapping. As rightly said, I think Mahipal and Chitra are doing LASIK before I started. I started in 1999. I think they started in 97 or 96.
97. Yeah.
97, yeah. So at that time we used to do -15, -14, and we had a head of 110, 130, and 160 on the microkeratome, and we never looked at the epithelium. And of course, things have changed a lot after that, and now we are at this stage today. So there has been an evolution even in the mapping of the epithelium itself. Previously, we had bad ultrasounds, and there was another machine called the Artemis, which was also looking at the epithelial mapping. But over a number of years, even that has changed, and now there are different modalities that are now available. So we have an OCT-based epithelial mapping, and I also have the Antirion, which also does epithelial mapping. So this has now become a necessity tool. It's like topography for all our refractive patients. So yes, when you have an ectatic cornea, which just looks like your other picture, we see a proper ectasia, there is no confusion at all. But the problem actually happens when it's subclinical and you are really not sure whether you should touch that patient or not touch that patient. So you can see the other image on the other side, the right side, where you can actually see a little bit of steepening inferiorly. So now OCT-based devices are at a wavelength of 830 with a width which covers almost central 6 millimeter and above. It covers the anterior and posterior curvature of the cornea at the same time and it's quite repeatable and quite reliable as far as the training is as far as the scanning is concerned. So it is a need of the today, that screening of every candidate, and when you have doubt, don't even think about it, you have to look at the corneal epithelium because it can unmask any irregularities which is there. It's very important to look at the epithelium besides the actual map or the topo map that we are looking at routinely. So this becomes in our routine checkup when it is pre-op. Of course, we have to do topo, tomo, ocular wavefront. Of course, you have to look at the other surfaces. But if there are any irregularities at the epithelial level, which has to be looked at because it will show an impending ectasia. So again, here another picture, you can see a good epithelium, 56, 50 all around, smooth, nothing to worry. This is a straightforward case. So now the role of epithelial mapping has become quite important. Irregular epithelium remodeling, especially when there is a regression, okay? So if a patient has undergone myopic LASIK or hyperopic LASIK and there is some amount of regression, just don't go ahead and do a surface or lift the flap and do a treatment because the epithelium could be remodeling at that level. So if you have a thicker epithelium than the pre-op epithelium, then some microns or some refractive error has come from the epithelium itself. Like the apical syndrome following hyperopic LASIK, very important to look at the center. Again, previous topographies and corneal thickness have to be used in your reanalysis, and direct measurements of the epithelial thickness is necessary, which can be customized in treatments today's world. So nowadays we have smart pulse or surface treatments possible. The epithelium you don't need to remove with any alcohol or mechanical. It is directly done by the laser itself. So you can see here just a little bit of comparison between the OCT and the Antirion, pretty close. So you can see a superior 59, and here we have a mean average of 51. So they are quite matching. You can, in Antirion, you can get from 0 to 2 and 6 to 7 mm. So it covers about 7 mm of your central cornea completely as far as the thickness of the epithelium is concerned. I'm just showing some examples. This is an abnormal looking inferior steepening. On the pentagram, we have the bad D, and the patient wants LASIK. So now the question is, what are you going to look at this case besides the other things? Again, look at the epithelium, very, very smooth, regular, no steepening in the area of the steepening, so then nothing really much to worry, and you can go ahead and do that. Another case where again superior abnormal looking cornea, again a bad D on the pentacam, and the patient wants refractive surgery. Again, we look at the epithelium, very smooth, really nothing much to worry. You can still go ahead and do this. Now, there are no red flags in this case at all. So you can see that everything is smooth. Paki is 546. But if you look at the Berlin map, look at the other one, you get a central red area, and the Berlin thing is going down, and the bad D is 2.45. So whenever you get this, don't worry, because look at the white to white. The white to white will be 10 and something, then you will get a central red area on the pentacam, and this is a flaw in the pentacam. It's nothing to do with your posterior float at all. So this is just to tell you that if this happens, make sure that you look at very thick corneas. A small white to white will appear like a bad D on the back surface of the cornea, and you will get worried about it, but really nothing much to worry. And again, you look at the epithelium in the same patient, very smooth, really nothing there. So you can still go ahead and do your laser surgery that you want, LASIK or lenticule or whatever you wish to do. Now, this is another suspicious case. You can see a steepening, and the patient had 6/9 vision. And you'll think that this is a subclinical case. But when you look at the epithelium, so you can see this, the left eye, the other eye, the steepening is not in the area where the steepening is on the pentacam. So it's in the opposite direction. So what would you do in this case scenario? What I think is, I did not touch this patient at that moment. You can do surface treatment. Either you give some cyclomune, cyclosporins, do some surface treatment, and then re-evaluate this patient, and then you can think whether you want to do, or you can, some doctors can do an extra on this. They go ahead and do a surface extra if necessary in case. But as you notice, it's not matching. So this can be looked at, that this could be just a little bit of epithelial modeling in another area, not in the area where the steepening is really there. Now, this is another interesting case which we discussed the other day. I think Chitra was there in the hall. This is a 25-year-old. All of us who do lenticule surgery, you see that it's a 3.5, 1.5 SIL. And here is a straightforward case. This is the right eye and this is the left eye. And I did lenticule treatment for this. Now, what happened was, patient was very happy with the right eye. But patient kept complaining about the left eye. And the lenticule surface, the lenticule surgery was smooth. Everything was fine. Even after 1.5 to 2 months, the patient complained of the left eye vision. So this is a pre-op epithelium, as you notice. The right eye and the left eye, everything is good, nothing to worry. But don't forget it's lenticule surgery, and this is the pre-op epithelium. And what you'll notice in the post-op epithelium is this. So this is the right eye, and this is the left eye. So you can see that there is epithelial remodeling in a lenticule procedure in one eye, and that can be the cause of patient's unhappiness in quality of vision post-op, even after a month, month and a half. So this is what we got in one patient, which was quite surprising. I had a discussion, actually, I think Chitra was present that time, and which was decided that this patient, of course, we treat with cyclomune surface, even do a punctal plug, and then go ahead and treat this patient. So this is just a little bit of few cases that I had to discuss. So in conclusion, no doubt that epithelial mapping is a need of the necessity today. We have to look at every case with epithelial mapping. If you want to do retreatment or regressions or anything like that, and you want to do a surface treatment, you need epithelial mapping. It will also unmask any stromal irregularities and makes ectasia prediction and management quite easy and approachable. So it ultimately, surface treatment becomes much easier once you have this tool of epithelial mapping. Lots of references here. Thank you for your attention.
Thank you, Kumar, for lovely videos and lot of important points which came through. That particular case of Smile, which had that kind of epithelium, I would primarily think whether it's a dry eye status, which is the issue, and evaluate it and treat it, and sometimes that could be the solution for that kind of epithelial irregularity. Shreyash, you saw that video, which you didn't see. A 3.5 Smile procedure, and he had some epithelial hypertrophy on the thing. So I would think primarily it could be a dry eye. There was no regression in that patient. So beyond that, would you do anything actively? Because only epithelium map is showing some issue. Patient is not visually disturbed.
So the question here is, all of you who are doing lenticule procedure, we normally tend to not look at the epithelium, even
Yes.
pre-operatively, because everything else is fine. So here the question is, have any of you done a post-op epithelial mapping on lenticule patients and noticed anything different? Because you removed a part of the stroma, does the epithelium try to compensate for that loss or whatever? What is your opinion of all those who are doing?
Remodeling.
There isn't a lot of epithelial remodeling. What is basically wrong is that the basement gets wrinkles. So
Bowman's,
that is the thing. That is what actually causes a slow recovery of vision and the contrast going down.
Yeah. So
you have shown.
No. So this was 1.5 months. So I understand what you are saying. So nowadays, what we are also
So
doing,
for
where the
that,
patient is.
you need to do an OCT to kind of look at the NHT OCT. You have to see the where it is, because the plano-convex lenticule doesn't fit that well.
Thank you.
The
Thank you, Dr.
compensatory
Kumar.
epithelial hyperplasia for regression itself happens very slowly and over a long period of time, sir. Very often, if it is in the early post-op, sorry, this is some echo. If it's in the early post-op, it's possible that during the initial surgery, you might have had some back end, some loose epithelium, some erosions in that, which while healing has temporarily caused a heaped up epithelium. And that's possibly why there is no refractive effect. If it was a long-term compensatory epithelial hyperplasia, we are likely to have.
So patient is just unhappy with the quality. That's what is the.
Thank you very much. Yeah.
Gaurav, it's your turn. तूने बोलना है, मैं बोलूँ?
Correct. Thank you.
So we go on to our next speaker. You can have your tea maybe. You ran, huh?
अब तू बैठ.
Okay. He has 2 other questions. Okay.
तूने बोलना है?
He has.
बोल.
Sorry. We go on to our next speaker, Dr. Gaurav Luthra, who is going to talk on the very much raging topic, contour vision. Like it's all over the place, and we all of us have been forced to remember that. But there are a lot of value attached to it. So we actually need to know what is the stance of contour LASIK and how it contributes in refractive surgery truly. So I hope Dr. Gaurav is going to give us a clear perception of the role of contour LASIK. यहाँ कोई fan नहीं है क्या?
नहीं.
हाँ? Dr. Gaurav Luthra again needs no introduction. He's a very leading cataract refractive surgeon of the country and has been doing amazing work in refractive surgery from Dehradun. And he's going to tell us something so relevant for us about contour LASIK.
Thank you, Dr. Chitra, for making me a part of your course. And it's always interesting because your course is always very engaging. And you had asked me to speak on Contura, which I've been doing for a few years. Let's try to see and understand where to use Contura in our practice. So contour, as we all understand, is representing the shape or form. So that's what we are doing with Contura LASIK, that trying to correct the topography of the cornea by doing a topography guided treatment. And I'm sure that if we have all refractive surgeons sitting here, they would be aware of the fact that we do wavefront optimized as one of the most predominant forms of laser correction. And then, many years back, wavefront guided treatments took fancy for all of us. And, somewhere way back in 2005 or 6, we all started playing with abrometry assisted treatments with wavefront guided treatments. But very soon we realized that it would work only for a few percentage of patients. And over time, we started doing Q value adjustments, giving them, enhanced Q values and playing with that. So the Q value based the FCAT treatments on the Wavelight platform and also on the other platforms in different names. And then last few years, we've understood that, many of these corneal aberrations are actually on the cornea. So it would be best suited to correct them with topography guided treatments, which have been around for more than 10-15 years as well. But Contura was born when FDA did a study for the US markets. The Alcon did a study for FDA trying to see that whether topography guided treatments were of any benefit on virgin eyes, which means not even corneally aberrated eyes, but on virgin eyes. And they were surprised to find that, the topography guided treatments on virgin eyes showed marginally better results than the wavefront optimized, and that was not even on aberrated eyes. So that's how Contura was born, and got that fancy name of Contura, which had always been around for many, many years before that, and we had been doing topo-guided treatments even before. And this is how it works. You do a topography on the wavelight laser with the topo vario topolizer, and then you import these maps into the wavelight machine and do the calculations, and then you can fire that treatment using the excimer laser. And Contura is basically a topo-guided treatment for virgin corneas, and you can of course do it for aberrated corneas as well. And we've already spoken of how Contura was born. So it tends to treat all the many of the pre-existing higher order aberrations and prevents induction of new higher order aberrations. And it's based on corneal topography, and it combines with the wavefront optimized treatment as well. And it is centered on the corneal vertex, so it's not influenced by the pupil centroid shift. So it tends to be much better in its application. So most lasers will fire on the pupil center. This will fire on the vertex of the cornea. And how it is different from wavefront optimized is that optimized is basically based only on the refractive prescription of the patient and the keratometric reading of the patient that helps decide the treatment protocol, whereas Contura will combine the prescription along with the topography maps and then put together a treatment, so that improves the quality of vision, which we all talk about. And of course, Contura vision is very different from wavefront guided, because we understand that 70% of the refractive errors are from the cornea, so correcting them will be much more important. Customized wavefront guided treatments would also include the lenticular aberrations. So if you have lenticular aberrations and you're trying to correct them on the cornea, it seems to be counterintuitive anyway. So Contura, when it was born, was by Alcon in 2017. They advised that treatment should be calculated based on patient's manifest refraction. And by ignoring the refractive effect of the topographic irregularities, surgeons were not getting great outcomes. So then came the TMRs when John Kalanopoulos developed this. And in this, they were basically relying totally on the topographic manifest refraction, but it led to, again, not great results. So this, when Contura had teething troubles initially, because the nomograms which Alcon was trying to propose were not giving us amazing results, and it took a long time before we understood that how to go about it. So who are the ideal candidates for Contura? It says 18 and older, but this is when Contura was, kind of approved by the FDA. But frankly, today I don't like to operate anybody below 21, and that too with stable refraction for at least 2-3 years. And Contura is usually done for virgin eyes and can be done for myopia and astigmatism, as is mentioned there. The main thing is that you should be having great maps. So if you don't have great topography maps, you will not be able to do a good Contura treatment. So there should be no dry spots, and there should be no data losses. There should be proper exposure. And you should not do Contura if you don't have good maps. We are trying to do enhancements, or you're doing stromal scars or PTK, or if there are significant lenticular changes or early cataract, because you'll end up making a mess of it. So as we go stepwise on how we can do Contura treatments, the step one is to get a great topography, as I told you. And this would be a good topography scan, as you can see. This, with lots of areas missing out over there, would not be a great topography scan, because much of the iris is actually covered with different artifacts. So if you have poor topography scans, the machine will usually tell you that you don't have great scans, and it basically uses 5 to 6 scans, and if all of them are good, then it tries to average them out and then forms a treatment plan for you. And but then you come to the planning when the data is sent to the machine, and we get a set of values. You can see this comes up on your excimer laser. I will not go into details, because this talk is not on how you would want to do Contura, but when to do Contura. But it's important to know that how the machine does it. So once the data is imported, then you can just kind of neutralize all the refractive error and see what the machine is actually going to do. This you can do by putting 0 at the final treatment plan. So what it shows eventually here is what the aberrations are going to be corrected, and you should have a look at this, what is the maximum and the minimum it is going to do, and the talus as well. So off late, we have moved on. This is how the treatment plan looks. And now the decision making on whether, if the axis and everything coincides, it becomes much easier. If your topographic astigmatism and your manifest astigmatism is matching, again, it becomes much easier to go ahead with the treatment. But when they don't match is when you have to actually take a decision on what you're going to do. And this is where, this new engine, software engine, which we use as Forcities, has come very useful, because it tends to simplify and make it make simple kind of a thing for you to understand how to go ahead with this treatment planning, because it works on the concept of the talus. Basically, talus is the irregularities on the cornea different from the normal corneal shape. So it's the secondary elevations on the cornea, which all are having a refractive effect and need to be corrected. And the planning software is free software for Indians, at least, made by Mark, I'm forgetting his name, Lobanov, and he's been kind enough to give it to many of us, and we are using it. So it basically does a vector analysis and it takes into account 4 things: the anterior corneal astigmatism, the talus astigmatism, the posterior corneal astigmatism, and some of the internal as well, and then comes out with a treatment plan. I will not go into the complexities of that, but just to show you a case, 22-year-old male, and acceptance was -1 sphere with -6 at 20, other eye -1 with 5.25 at 155. So cyclotorsion is going to be very, very important for this patient. And if you look at the maps here, the symmetric bow ties, look at the bad maps are good. The aberrations are there, of course, but if you look at the eye trace, you'll see that the corneal aberrations are much, much higher than the internal aberrations over there. So this is an ideal case for doing a Contura treatment because has high astigmatism, good epithelium maps, good maps on the anterior. So what should we do? I would have done either a toric ICL or I would have gone for a Contura LASIK. Patient was more keen to do a LASIK procedure, use the faucets for the planning, and these are the taluses which come up when you feed the data. And this is the final treatment plan at the bottom. So it's taking into account your refractive error and your measured astigmatism from the topography and giving you a final plan. As you can see, the manifest is at 20 degrees. The Contura recommended from topography is 12. The pentacam is giving anterior at 13 degrees and the posterior cornea is at 102. So they all match up. And then this is the final treatment plan. And these work really well. We've been doing it for about 4 or 5 years. Contura tends to really give well. And when it doesn't work, it tells you that don't do a Contura here at all. Tells you to go do a wavefront optimized, and it really makes life much easier. So these were the post-op maps. Patient did extremely well. This was the right eye, and this is the left eye. Had very high quality vision with very good correction of the astigmatism as well. So I think post-op day 1 patient was 6 parts. The refraction is right at the bottom, and you can see that if you consider the kind of astigmatism he had. Coming to the finishing, I would like to finish by saying that Porcities has been a great transformation for us. We were struggling with Contura right in the beginning. It has helped us improve our outcomes. And it also tells you when to use Contura and when to switch to wavefront optimize. And quality data capture is the key, and a good planning. So when somebody says, I do 100 Conturas a day, you have to take it with a pinch of salt. It requires good 15 minutes or 20 minutes to do these plans, sit for each patient, and then execution also takes much more time. So final conclusion, hyperopia, because it treats on visual axis, can be a good option for Contura, but it's a difficult planning on the Porcities doesn't plan for hyperopia. High astigmatism with good cyclotorsion control, very high corneal aberrations, and many times now patient wants it and comes asking for Contura, although now they come asking for silk more often than Contura. Yet, some patients will come seeking Contura, and then you have no choice. If it's not doing harm to the patient, you can still go ahead. And we all understand that new technology is really helping us. And with that, thank you so much for inviting me, ma'am.
Thank you. Thank you, Dr. Gaurav. Any particular question you would have to talk when you would not do a Contura LASIK?
So there will be
Very
times.
brief.
Yeah, there will be
and
times.
I would want the next speaker, Dr. Mahipal, to.
There will be times when there will be huge disparity between what the topography picks up as the astigmatism or the aberrations, and is suggesting a totally different plan than what is your manifest. This typically will happen in suspect corneas or on corneas. There it may be a better idea to just go with a topo guided treatment rather than a Porcities.
Wavefront optimized treatment. Then,
of course, wavefront optimized, but I'm talking about keratoconic corneas where there's huge irregular astigmatism. There you may do a topo guided PRK CXL, but otherwise 90% of the times, if the two things are not matching at all, which means that your Contura planning is not matching with your manifest at all, I would go with wavefront optimized. That's the take home message. Can't force a Contura treatment on every eye.
would you prefer to do, whenever there's more astigmatism, do you feel doing Contura is better than doing smile?
Absolutely, absolutely. So in fact, my second case, which I didn't show, was typically one where one eye we did smile and second eye we did Contura, because there the astigmatism was like much more than the sphere, and patient had great outcomes in both eyes. So with high astigmatism, which is higher than the sphere at least, I will always go for Contura than for smile in that case.
Supposing you had cyclotorsion compensation then?
Yeah, so we do cyclotortion compensation even on smile, but I feel Contura still has slightly better outcomes. And Dr. Mahipal is still not convinced about it, even though he has a machine. But I will convince you one day.
Yes, it is. Now, I think each of the machines have their own advantage, and we should fine-tune them to the procedure which we want. And of course, before Contura came, we were doing higher cylinders and doing well with smile, but there's some kind of a precision which the Contura patients have in high cylinders. Thank you very much, Gaurav, for bringing out the points. We go on to our next speaker, Dr. Mahipal Sachdev, who needs no introduction. He is like a Tipu Sultan of our country in having hospitals all over the place. And he's going to tell us, as a man who likes to be challenged, so I thought this topic would suit him best. So post-LASIK challenges. So let us hear from him and do stick to time, and the timer should be on for all of us, please.
Thank you very much, Dr.
AC
Chitra.
बीच में on होता है, off हो रहा है, AC constantly
AC
on
है
होना
नहीं
है.
भाई, ये exhaust anyway. So your simile for Tipu Sultan is wrong because I am not in South India. That's been left to you people. Anyway, so I'll be talking about, she always gives me the challenges or the post-op complications because I am very adept at causing complications. So we'll be talking about complications of LASIK. So there are several complications. The first and the foremost that you need to tell every patient, I really don't put that as a complication, but under or over correction is something that is part and parcel of any treatment that you are doing. Induced astigmatism, then you are talking, this is something that used to be there, central island. The first machine that we had in 1997 was a Summit machine, which was a broad beam laser, and you used to have what is called as a central island. So basically the etiology was not fully known, but it was the hydration of the center or the plume coming in the central part. So what you had was an unablated area, but with the flying spot technology, I think it's more for academic interest that central islands used to happen. Again, because there wasn't an eye tracking, there wasn't a locking on the center, so there you could get a decentered ablation, and that could be totally off what it was. Then with the more longer ablations, there was a drying, so therefore what has happened now is that you have faster lasers, so the time that is taken for the laser treatment, excimer treatment has gone down dramatically. Otherwise, if you are doing a hyperopic correction, which was say a +5 or something like that, it would take more than a minute and a half for the laser to take care. Now the second part, this is as regards the refractive part and the laser part, and then you look at the flap part. So you could have a buttonhole, you could have free caps, you could have epithelial defects, wrinkles, strias, you could have decentration of the flap, inflammation, DLK, epithelial ingrowth and infection, which is rare because the excimer itself is a sterilizing mechanism, because it's a UV light and it kind of burns everything that is there, and you could get haze in surface ablation. So these were the kind of complications. Again, majority of us, there is still lenticule, there is still a microkeratome that is being used by people, but when you are looking at a femto, you don't get buttonholes and you don't get free cap. So that complication rates have also gone down. This is just to show you a DLK, whether it's a DLK or a CTK, that's central corneal toxicity. You need to differentiate that, but this is a kind of an opacity, and the dictum is intervene early. And what the intervention is that you have to just relift the flap and you have to wash it from both the sides, under surface as also this. You can put a small dose of interface in the interface, an antibiotic and a steroid if you are sure that it is DLK, because it's an inflammatory response. So you do that and then you put back the whole thing. So this is what you need to do on a DLK. This is a typical picture which you could get more so in flaps which were made by the microkeratome. The second thing is, if you are doing a flat relift, as I showed you in the previous case, the incidence of epithelial ingrowth goes up because the flap adherence is poor. So this is what you get and also hyperopic flaps. So these are where you get more of epithelial ingrowth. This again has been left, not my case, was referred to us. So this is an epithelial ingrowth. You have to see where the track is, and this has been there for a long time. Again, the idea is to relift the flap. As you can see, this is the flap, you have to relift it, and whatever is this epithelial ingrowth which is there, you can see here, you can perforate at this particular point because there has been collagen melting. So you need to be very careful, as you can see, and see the loose epithelium that is there, the nests that have been created. You just need to go ahead and wash it. Now the question is, some people use mitomycin C, some people use ethanol, and some people obviously put glue, a bandage contact lens with a glue to seal, because as it is, there is an epithelial ingrowth and you have relifted a flap, then there is a problem. And see, this is the hockey stick that I am using to actually take this out, whatever is there. Mitomycin C and ethanol, both of them I use, and I put a bandage contact lens with a glue that you can see. You have to do remove it both from the undersurface, and you can see that's where the whole thing was. You can see that there is the collagen and this is the glue that is being applied, and then you put a bandage contact lens, so this will take care of the situation. This is इसका video कहाँ है? Okay, I'll show you something. Because I think there are only 2 minutes left. This is a case of a flap stria. Mind you, this case was done in a great tertiary teaching educational institution, and this is something more than 10 years old. This is what the patient came. The patient then went to the Apex institution. They did a wash and they said that the stria are gone. But this is what the patient came to me, a school teacher from Amity, and this is what you have to do in a stria. The most important thing is that you just can't go if the stria are of this kind. First is do a retro elimination. That is when you see the stria. Then you necessarily have to remove the epithelium. There is an anchorage in the epithelium. The epithelium anchorage will be in the folds that are there, and if you just put fluid and kind of say that, okay, I have stretched it out, it is not going to work. So what is very important is that you have to be patient, you have to remove the epithelium, then swell up the stroma with hypotonic saline. Okay, whether you put distilled water, combination of distilled water or that, then what you have to do is that you have to try to iron out the folds, and what has also been described that you can take a spatula. If you take a spatula and warm it up to about 45 degrees, above that the collagen will shrink. You will be able to kind of get these stria out. So you can see in this particular case that this is the area where if it was not applanating on the table, you will never have the entire stria disappear. You will always keep on seeing the stria, but once you have removed the epithelium, you have opposed it very well, and you have made it to swell. The thing will fall back, and this is what the patient had one day post-op, 6 by 7.5, and I think the picture has been put at a different place. This is 10 years hence. This is the same lady who came to me a week ago, and somehow I recognized her by the eye. So it's not that she said this. So I said, weren't you the person? She said that you fixed my eye, etc., etc. And this is what the thing looks like 10 years later. So the stria, the take-home message is, if it is early intervention, it is fine. Day one you are doing it, you can actually do it. But if it is something later, and if there are macrostria or there are stria, patients often come telling you, I feel miserable, my vision is not good. You say everything looks fine. Important thing is just go back and do a retro illumination, dilate the pupil, do a retro illumination and see if there are stria or not. So that is something which is very important, that is there. Anyway, ectasia and regression are something that you need to make out the difference. In ectasia, obviously a pentacam would be required for you to see whether there is an ectasia or not. And when you are doing a regression, that means that you are going to do a relift. In our earlier days when we didn't have the AIOC2024. So what you would do is that you would actually need to do a central pachymeter after lifting the flap, because the flap standard deviations were very large. When you were doing a blade microkeratome, and if you were cutting a 140 or a 160 flap, you could actually end up with 200 or whatever. So the standard deviation, so what is the residual bed needed to be seen? So even today the residual bed needs to be seen, but you can see it with an AIOC2024. That is important for you to do an AIOC2024. And again, the question is whether to do a relift or to do a recut. In a femto, you can do a recut by making it smaller, and if you have the whole thing that is available, we have cut 110 micron or 120, you can go in the same plane, or you can just do a fresh side cut. That is what people do, that you just do a fresh side cut. But this is the typical thing. This is several years after that. This is a relift. Epithelial ingos, just do this. Dry it, depress it, get like it looks like a line that you can see, and then you can easily enter. So the key is just dry up the area where the flap is supposed to be. You can see it on the microscope. I have never marked this. People say you might, on a slit lamp you mark it, etc., etc. You just need to dry and depress. If you want, I can show you again. This is, see this, just dry it, depress it, that thing comes into play and you can actually easily lift it. So I think that's about it, Dr. Chitra, that's what my time allows. And one important thing is for ectasias, believe me, a cross-linking alone in a post-LASIK ectasia does not work. We always combine it with an intax. I haven't done cares, but you need to, because you are basically cross-linking the flap. So that's not going to stop the entire procedure, whether it's a silk or a smile or, sorry, a silk is too early for me to get ectasias, but whether it's a lenticule or whether it is a flap, you need to do a cross-linking and do it the earliest. Cross-linking with an intracorneal ring segment. So that's all that I'll wish to say. Thank you very much for your kind attention.
Thank you. Thank you, Dr. Mahipal. As far as, while Dr. Ramamurthy gets connected, as far as the epithelial ingrowth, all that he said was exactly the way it to be done. But we could also debride the epithelium beyond the flap, because sometimes in the process of manipulation of flap, some epithelial seeding can occur. So if you debride the epithelium beyond the flap, and if you're using mitomycin, debride it on the stromal bed and the undersurface of the flap and place mitomycin on both sides and then wash it off. Could be a further thing beyond the glue which he suggested. And of course, as far as the flaps tray, I think we covered it. Thank you very much, Dr. Mahipal. I do hope you stay on. There's going to be some very good case discussions by Shreya Ramamurthy. We go on to our next speaker, Dr. Ramamurthy again, who's a doyen in refractive surgery and has been taken AIOS to a different level during his chairpersonship, and he is going to talk on a topic where we still don't have answers. Corneal biomechanics, what do we understand today? On to you.
Thank you, Chitra. Pleasure to be part of this course. I'll be speaking on corneal biomechanics. It's a sort of shift of gears from what we actually do to what we should actually be doing. This is a cohesive tensile strength of the cornea and the rest of the anterior segment. If you just have a look at it, the sclera is the strongest. Naturally, it has to be. Then the Bowman's membrane, then the peripheral anterior anterior third, and then the central anterior third, the peripheral posterior 2/3, and the central posterior 2/3. And the Descemet's membrane is the weakest. So suffice to say that the anterior 1/3 of the stroma is much stronger. It's almost 50% as strong as the mid and the posterior stroma. And it's essentially because of the arrangement of the fibers there. The collagen fibers form a meshwork of interwoven fibers which are getting implanted in the Bowman's membrane, while in the mid and the posterior stroma, the fibers are running parallel to each other from limbus to limbus, because of which the rigidity of the cornea in the mid and the posterior stroma is somewhat less. And in the periphery again, the arrangement is quite different, whether it's the anterior or the posterior aspect, because in the periphery, the peripheral fibers have a circumferential arrangement, and hence they are supposed to be more tolerant as far as the intraocular pressure fluctuations are concerned. Why are we so concerned about corneal biomechanics? It's estimated that about 60 million laser vision correction have been done so far, and now worldwide we are doing about 4 million laser vision corrections per year. And the incidence of corneal ectasia is about points. Different studies have shown varying from anything from 0.04 to 0.6% develop ectasia. Might appear like an extremely small number, especially if you adhere to all the rules before taking up a patient for laser vision correction. But then sheerly because of the number of procedures that are being done, we do come across these patients off and on in our clinical practice in spite of adhering to all the principles of preoperative evaluations. The LASIK is supposed to weaken the cornea by 55 to 65%, and 96% of the ectasia worldwide so far has been caused by LASIK. PRK, on the other hand, weakens by 20%. And the ever controversial subject remains that whether SMILE is better than LASIK as far as corneal biomechanics is concerned, simply because it removes stroma from the mid and the deeper layers of the cornea, which is supposed to be under the anterior stroma, which is denser and which is more has greater hysteresis, is preserved. But then the answer is unequivocal. Different studies have shown that SMILE is not significantly better than LASIK as far as corneal hysteresis is concerned, and your selection criteria do not change. So over the years, we have been doing in LASIK for almost 25 years. Initially, our first pamphlet said minus 30 diopters will go ahead and treat you with LASIK. Not because we were unethical, simply because we did not know. We started doing LASIK in 1997, and the word corneal keratoconus was coined in the year 2002. So obviously, not all those patients went into ectasia. And again, there have been cases of minus 2 diopters with absolutely normal looking corneas which develop an ectasia. So obviously, just looking at the corneal thickness as well as the corneal topography is not adequate. And a preoperative biomechanical status evaluation is extremely important, because essentially it's the eyes which are at risk because of certain biomechanical compromise as far as the cornea is concerned. Because of the further impact of the laser vision correction, it goes on to develop a iatrogenic keratoconus. Again, you also have keratoconus. The incidence is variably reported. 1 in 2,000 depends upon the genetic and the ethnic population about which we are talking about. And we have a very definite treatment as far as arresting keratoconus is concerned by way of CXL. But then the iatrogenic keratoconus and keratoconus are two classical cases where diagnosis is lagging behind treatment. We have very definitive treatment for the conditions, but the way to establish that the patient is predisposed to keratoconus or has early keratoconus is difficult to predict. Again, from the healthy to manifest slit lamp keratoconus, it's a continuum where you have a healthy keratoconus, then there is a change in elastic modulus of the cornea, which cannot be picked up by any of the instrumentation that's available to us. The biomechanical keratoconus, which essentially is the subject matter of my talk, the tomographically biomechanical keratoconus, the tomographically evident keratoconus, where there are changes in the back of the cornea, the topographically evident keratoconus, where we will obviously not go ahead and treat with CXL, not take up these patients, and then the manifest slit lamp keratoconus, in which case you have missed the bus and you are taking on the patient too late. So the idea is to not allow the patient to progress on to these stages, but identify the condition at this level so that you can interfere to arrest the progression of a nascent keratoconus, and also not insult such a weak cornea by performing a laser vision correction on such an eye. You had aura, but we had that instrument for almost a decade and a half, gave it up, but now what we are using is the Corvus, and essentially there is an air pressure pulse which causes a corneal deformation, and using ultra high sound Scheimpflug camera, we get about 16 corneal parameters that are generated, and this is clubbed together as a CBI. And what you see over here between the weak cornea and the normal cornea, the amount of depression that takes place in a weak normal cornea is significantly less than the weak cornea. And also the shorter applanation length. These have all been factors have been clubbed together by Vincigura and co-authors to give us what's called I am not going to go into all these details because time doesn't permit it, but suffice it to say this corneal biomechanical index is something that you get with the Corvus, and that's a useful index for us to evaluate. We use the machine in conjunction with the Pentacam so as to give what's called a tomographic biomechanical index, where the data from the CBI, the BAD-D, the CBI is from the...
Now coming to the expanded indications. The first one is bioptics. As we'll see each one of these a little more in detail, it can be used in combination with LASIK SMILE or PRK for very high myopia. The second thing is in keratoconus after C3R or in stable keratoconus where the best corrected vision is greater than 6/12, phakic lenses can be considered. Or after C3R, intrastromal rings, or even after topo-guided PRK to correct the residual power, phakic lenses can be used. It can be even used in combination with penetrating keratoplasty or DALC. Now the newer phakic lenses can be even used for the correction of presbyopia. Monovision with phakic lenses can be done, or just directly use the presbyopic phakic IOLs. Phakic IOLs have been used also in pediatric eyes with high anisometropia and amblyopia. It can cause amblyopia reversal as well, and it can be used as a piggyback lens to correct pseudophakic residual refractive error. So let's just look at all these cases. The first case, this was a patient with very high myopia, about 23 diopters of myopia, and initially a phakic IOL was done, and after the phakic IOL there was a residual refraction of about -4, which was corrected by doing SMILE. So the SMILE was actually done 3 weeks after the phakic IOL, and the patient improved to 6/9 uncorrected vision. So this is a great way for very high myopes to combine your keratorefractive procedures with the phakic IOL with a 3-week gap. This is a technique here that's been used called lenticuloschisis. Very good energy optimization and bubble pattern is required, and this technique is reserved for more advanced surgeons. This is Dr. Ganesh doing the procedure here using a lenticule holding forceps. And that's the end of this case. Let's move on to the next indication, Kerarings with ICL. Now here, this is a patient with keratoconus that has been treated using Kerarings and C3R. And post this procedure, it's very important to wait for anywhere between 3 to 6 months for the refraction to stabilize and the cornea to fully heal before undergoing the ICL. ICL procedure itself is a routine procedure. Here, the cannula that you're seeing is the Ganesh toric ICL manipulator. This is just a cannula with a sandblasted undersurface, so it has a rough undersurface, and in a single incision the ICL can be implanted. Here we are seeing a post-DALC eye. After DALC, it is very important to monitor and observe the patient for a minimum of 1 year for the refraction to stabilize and for the healing to be done. In all of these cases, it's important to note that the technique of ICL is quite similar. It's a routine ICL implantation. Here we use a markerless system, the Callisto eye, which has this overlay, and we use it to position the ICL. This is the routine procedure of ICL. Now coming to a pediatric ICL. This is a case of a 9-year-old boy who had high myopic astigmatism and anisometropia in the right eye with amblyopia and underwent toric ICL in March 2008. His refraction was -13 and -3 cylinders at 5 degrees, and his best corrected vision 6/36. A toric ICL was implanted and positioned under IV anesthesia, and a peripheral iridectomy was performed using the vitrector. Post-op vision improved to uncorrected visual acuity of 6/9 parts, and after amblyopia therapy, his vision did improve to 6/9. So there is a certain degree in very young children, when the refractive error is fully corrected, there is a certain degree of reversal of amblyopia, which we have seen. At this point, in the span of over 15 years, Dr. Ganesh has done more than 12 cases of pediatric ICL implantation with excellent results. This was one of the first few cases. And again, it's a standard technique of ICL implantation. So this is a very interesting case which we recently published in the American Journal of Ophthalmology case reports. You see here that the patient has undergone ICL implantation, after which he has developed an anterior subcapsular cataract, and a cataract surgery is planned for this patient. So what is being done is two of the haptics have been externalized and placed on top of the iris. The rhexis is done under the ICL, and the cataract surgery is performed under the ICL itself. The reason for this being that the ICL in this case has been used as a piggyback lens along with the IOL to correct a high degree of myopia. So you see here the phacoaspiration is done because it's a very soft lens. It's an anterior subcapsular cataract, and a coaxial IA is just used to aspirate the lens and the cortex, and the IOL is injected. You can see here that the IOL is injected beneath the ICL. So throughout this entire case, the ICL is in place, and the entire cataract surgery is done while the ICL is in situ. So the surgical technique is slightly more challenging and is reserved for advanced surgeons. But what is interesting to see here in this case is the correction of myopia. This patient would have required a highly customized lens, and without using a customized lens, we were able to correct the myopia. So this is how the biometry was calculated. The initial refractive error before the ICL was plus 13. It was a hyperopic eye. Residual refractive error after ICL was about plus 4 diopters in the right eye. So the ICL has corrected about 9 diopters. Therefore, the target refraction for biometry was kept as 9 diopters, and the patient had a cylinder of plus 1.69. And to aim for a slightly myopic astigmatism, the target refraction was entered in the biometry as plus 9.5 diopters. So the target refraction here was the total pre-ICL procedure minus the ICL subjective refraction minus the post-ICL residual refraction. So the resulting IOL power required was calculated to be plus 30, which in this patient was not very affordable. So the IOL power that was calculated was kept with a target refraction of plus 9.5, and that particular IOL was implanted. This patient ended up with a 6/6 parts vision. Now coming to the last expanded indication for ICLs, this is for presbyopia. So the Star ICL has recently launched the Evo Viva ICL in India. We have implanted only 2 of these ICLs so far with good results. This is basically a presbyopic ICL. The principle is it's an EDOF lens, so it has a spherical aberration, and this is supposed to correct the presbyopia as well. So this is indicated in patients above 40 for presbyopia correction. This is the design of the lens. It has a smooth radial variation in power across the optic from the center to the periphery. It's a wavefront reshaping design, and there's no diffractive rings for presbyopia correction, and it provides more power. The periphery provides more power than the center, and the central region has a slightly myopic region to provide near vision. It's designed to, again, provide an additional depth of focus. So with this, I end my talk. Thank you very much for your patient listening, and Chitra ma'am, thank you again for including.
Thank you, Supriya. That was a wonderful talk, very well covered with all that is new and needed, and I'm so glad you made it so refreshingly good. We go on to Dr. Ramamurthy, who's going to present some challenging case discussions, and I would definitely want Supriya, Mahipal, and Ramamurthy to add their thoughts as to how they could have been managed differently, or their thoughts on it. We have about 15 minutes, so let's cover it.
So thank you so much, and good afternoon, everyone. So I'll just be taking you all through a few case scenarios, most of them which are more common, but have something unusual in them, which we may face commonly in our day-to-day practice, and how we can go about handling them. So this is first patient is a 24-year-old male patient who had undergone PRK elsewhere for 4 diopter sphere in Kerala, and had a progressive decline in vision for the last 2 months in the left eye. And he had when he presented to us, his best corrected visual acuity had dropped down to 618. And this was the clinical picture, where you can see he had a significant reticulate scarring in this region, where you see a typical of a post-PRK haze, along with a hypertrophic epithelium and a hypertrophic scar. Now, we have to differentiate this from a routine post-PRK central haze. This is something which is a little unusual, something where this is an exuberant healing tendency which a patient may have. And you can see here that this is the way the underlying stroma itself, it's not very deep, although it looks large. It's just primarily because of the epithelial hypertrophy that it is appearing heaped up, and only the very limited portion of the anterior stroma is involved. If it was a little deeper, a PTK would not be sufficient, and we would probably have to go in for an anterior lamellar keratoplasty. But in this situation, I decided to go ahead with a superficial keratectomy followed by PTK. This is video from a different patient, but it's just to discuss what we have done. Is essentially important to loosen the epithelium using either alcohol or paracaine, and then you can scrape off the epithelium. Now, when you're doing it, in all the other areas where the scarring is not involved, it will come off in a single layer. But here you will see that it keeps coming in multiple layers. And actually, you can even sometimes hold the edge of it and peel it off entirely, or you can just scrape. And as you can see here in this region, it's coming out in layers, and this is essentially the heaped up portion of the epithelium and the subtle anterior stromal scarring, which can be removed. Once this is done, to smoothen the bed, we can do a PTK. But now we have to apply a mitomycin C for a much longer period, for about 2 minutes or so, to ensure that this kind of scarring does not recur again. Now, this is a likelihood that this is a patient who has a keloid tendency. This is the first surgery. He's a 24-year-old. This is the first surgery he has ever undergone. So we don't really have history of keloids as such in this patient. But this kind of exuberant scarring is less likely to happen. Now, in such cases, again, you have to anticipate a high degree of recurrence. This is early postoperative period. You can see that the scarring has been completely removed. This is just epithelial stippling. Epithelium is taking a little longer to remove, heal. You have to leave the BCL on for a much longer time. The patient also was prone to multiple episodes of surface inflammation, had to be kept on steroids for a much longer time, a little stronger steroids, to ensure that the amount of heaping doesn't come back. And you can see that the AIOCT is looking fairly smooth. The anterior corneal curvature is restored. But still, the patient had a subtle scarring which did alter and induce a significant astigmatism. And while the best spectacle corrected visual acuity did improve, because of the higher degree of anisometropia, patient was not very comfortable with the glasses and required a contact lens trial with which the patient's vision improved to 6.6. But it still continues that even despite the initial management, over a period of time, slowly the scar can come back and then it remains stable. But the idea behind this entire thing is what was originally heaped up and elevated has now become a flat, subtle, uniform scar. And this is still amenable to contact lenses as well as spectacles, which the patient was intolerant to earlier. We could not even do a contact lens fitting in the first place. So there will be tendency for recurrence, but if managed well, we can end up with a less exuberant healing, which will allow us to manage the patient. So these are the questions which come to mind, steps to avoid this complication, any different approach in handling this which we have done, and what can we do to prevent recurrence. Any thoughts, any inputs?
No, now the amount of cylinders seems to have gone up post lifting, but the BCVA has improved. So do we presume that over a period of time with the scarring and flattening out, the astigmatism may reduce? Was the patient happy after what was done?
So essentially, the preoperatively also I didn't put up the topography pictures, but it was a very irregular cornea. So it's just that we could not really refract the patient properly when the scar was there. And now with the subtle scarring, we are getting a better reflex, and the central reflex is clearer, and we are able to neutralize the refraction better. But it's not that the procedure has induced an astigmatism, but it is the subtle scarring, and you can see that typical paracentral scar, it's almost like an artificial intax which has been done, which is causing in that area a specific flattening and steepening along the opposite axis and inducing a...
Did he have a lot of dryness? What could have been the reason to have such an inflammatory response in this eye?
So he kept having waves of surface inflammation, kept having episodes of congestion. So this is something, that's why in the early post-op, maybe even in the first time when he underwent the PRK, if it had been managed adequately, if he had given sufficiently long period of steroids, not removing the BCL till the epithelium is completely stabilized, UV protection, all this would help in reducing the amount of scarring. And of course, a mitomycin C kept for a much longer period in the first instance. However, we really don't know which patients may go in for such keloid tendencies.
Can you go on to your next case?
Yeah, sure. So it can be done, but see, at the end of the day, it may work in a condition like OSSN, whereas with this kind of, where the procedure is what is causing activation of fibroblasts, and it is not an ongoing condition, it is the initial management which becomes key. Once it is stabilized, generally it does not develop progressive scarring. It's the initial delay in healing, initial inflammation, which leads on to the haze and then progressive scarring. Yeah. So the aim of PTK here is different. It is not just to remove the scar. Removing the scar was majority done by the superficial keratectomy itself. It is to smoothen the bed that we are doing a PTK. So decentering the PTK may not really help in smoothening the bed itself. If it is very irregular, we have to even use a little bit of masking agent, put a little drop of CMC so that it fills in the troughs which are there in the epithelium, and then we can go ahead and do a PTK which will result in a much more smoother and uniform bed. And this having a uniform bed is also important for proper epithelialization to take place and for no hypertrophy to happen. There must have been something in the initial episode, somewhere, some problem, which led to, you can see even while I was scraping, there was a small divot in the stroma. And that improper healing or irregular surface is what has led to an excessive scarring also.
Can we?
So yeah, so up to 100 micron, generally we could do a PTK. Generally beyond that, I would go in for a ALK, DALK if it is really significant. But manual ALK or a femtosecond assisted ALK also works reasonably well. Yes, there will still be some interface irregularity. It will take some time for the BCVA to improve and settle down. But at least you don't have the suture related issues which a DAL can have, which makes it a much longer recovery. And so I'll run through these two cases quickly. They're aligned with each other. This is a 26-year-old female, stable power for the last 5 years since the age of 21. High myopia, but anisometropia. The right eye is a moderate myopia, left eye being a high myope. The corneal topography was normal, slightly thinner corneas, where we decided to go ahead with a phakic IOL. Patient had a good outcome following the toric phakic IOL initially. After 3 years, presented with a new onset of this kind of myopia or regression or progression, as you would call it. Now, it has become a routine practice to take biometric measurements for patients both pre-op and post-operatively. And you can see that in this eye, the right eye and the left eye has actually the axial length has progressed. Even the eye with a reasonably moderate myopia has also progressed from 24.7 to 25.5, and this from 27.02 to 27.63. So this 0.8 and 0.6 is what has really induced the myopia, and there has actually been an increase in axial length. I'll just add with this case also because both are interlinked together. Now this is again a patient with anisometropia. The right eye was a relatively low myope with some cylinder, and the left eye was a moderate myopia with cylinder. Patient, again, normal topography, slightly thinner corneas, in their mid-20s. The first patient was 27, the second patient was 24. 4 years after the IPCL, the patient was maintaining stable refraction with a very small cylindrical residual, which was there right from day one. The patient was happy with the vision. 1 year later, patient presented with a significant shift in myopia. And the only incident that had happened during that 1 year was that she had a pregnancy and she had delivered a child, and this was 4 months after the delivery of the child. And this was a unilateral myopia, and this was unilateral myopia in the eye which had the lower myopia. It was just 1.5 to begin with, and she had a significant increase. And as you can see here with the axial length, it has increased from 23.82 to 25 in the right eye, whereas the left eye is almost the same, the eye with the higher myope. So more and more as we go on, we are seeing more of these cases. I mean, our counseling for phakic IOL used to be that with LASIK you may get back a power, but with phakic IOL generally you won't get back a power unless they were extremely high myopes. We expect some myopia progression in staphylomatous eyes, where the eyeball growth continues to happen, the staphyloma continues to increase, and some myopia may happen. But even in these mild to moderate myopes, we are seeing patients with a progression myopia. Was pregnancy a risk factor in axial length elongation? We always knew that some curvatural myopia, biomechanical weakening can happen, but the topography was stable, but the axial length prolonged. So I've presented 2 cases, but we have more of these cases happening nowadays, and something for us to ponder over even in our initial counseling and planning.
Thank you, Shreyash. That was a wonderful talk. I think the youngsters were the best in this. And thank you very, very much for all of you who are there for this course. I'm sure you would have learned something and gained something more. Thank you very much.